Thank you very much, Mr. Chairman. You may wonder how this topic fits into a session on early intervention. Although it's obvious to many of you, I just want to make it very clear that it's one of the problems that's bedeviled so many interventional studies in acute pancreatitis is that we don't actually have accurate enough predictors of patient subgroups. So if we're going forward and we're going to propose that we should trial a new intervention, it is absolutely fundamental that we do better than we have done in terms of predicting severity or any other outcome that we want. So the reality is, as we stand today, and to quote Bono, we still really haven't found what we're looking for. We know what we're looking for because we can define what an ideal prognostic factor should be. And I've listed some of these variables here. We want a singles test. We want a simple, quick, safe, objective, repeatable, reliable, available, and cheap test. But also we want one that's highly specific, that's not affected by other comorbidities or cofactors. And I think very important and relevant to this particular talk is we want high utility. That means we want one that is very useful for the individual patient because as clinicians we face the individual, not a group of patients. There's a number of problems that we face in this field, and the first one is that we have an absolute massive literature to deal with. And this was published last year, which just gives you some idea that we're dealing here with a growth industry. If you want your resident to get a paper out quickly, try another predictor in acute pancreatitis. Second problem I think we're faced with is that guidelines are discordant, and really their suggestions are often impractical. And that's not a reflection on the guideline authors, it's a reflection of the fact that they're dealing with pretty poor data. 26 published guidelines at my last count from 15 different bodies, little consensus and some interesting differences. The best and I think most recent guidelines are those shown there, and this is an example of what I'm talking about. This is put up as a recommendation. We need to do 4 different things on the initial assessment, 5 at 24 hours, and repeat it again at 48 hours. That's complicated. I think that's not the ideal. That's not what we really want to head to.